Hi, everybody. Good morning. Thanks for coming today. It is my great pleasure to introduce you to Dr. Deb Albirght. She's an assistant professor of pediatrics at the University of Pittsburgh School of Medicine, right here, board certified in allergy and immunology. She's currently practicing here at UPMC Children's Hospital of Pittsburgh, and she joined us in the Division of Allergy and Immunology in 2017 after practicing general pediatrics and allergy and immunology in the United States Air Force for 10 years, followed by employment in private practice for 10 years. She completed her pediatric residency at the Wright-Patterson Air Force Base, Wright State Integrated Pediatrics Residency Program, and she was selected as co-chief resident at the Dayton Children's Hospital. Then she served as general pediatrician and faculty at Wright-Patterson Air Force Base and then Luke Air Force Base before completing AI fellowship at the Wilford Hall Medical Center at Lackland Air Force Base, Texas. During her time in the military, she was an assistant professor of pediatrics at the Uniformed Services University of Health Sciences and at Wright State University, Boonshoft School of Medicine. Dr. Albirght is the primary site investigator on numerous food allergy research studies, and she fulfilled the position of the UPMC Children's Hospital Pittsburgh Advanced Practice Provider Physician Liaison for the AI curriculum before she was promoted to the director of the Food Allergy Center in January 2024. Her interests include quality of care initiatives, food allergy prevention management, and aeroallergen and food allergen immunotherapy.
Well, good morning, everyone, and thank you, Dr. Chong, for that introduction. I'd like to thank Dr. Spears and Dr. Dermody and Savannah and Dr. Chong for the opportunity to talk to the Children's Nation today. And I thank everyone in the audience for being here and those who are listening in online today as I speak on behalf of our allergy division about the many evolving and exciting changes that have exploded in the field of food allergy over the last several years. And if you haven't figured it out already, in the spirit of one of my all-time favorite shows, Sesame Street, the letter for today is E. Yes, yes. So I don't really have any real disclosures. I do serve as a primary investigator for the UPMC Children's Hospital of Pittsburgh site on several prior and current industry trials involving food allergy immunotherapy. I do not, however, receive any compensation in any form for this. My objectives today are to briefly review the prevalence of IgE-mediated food allergies in the United States and beyond, along with the standard of care for food allergy as of June 2024, before I delve into the evolving approach to primary prevention of food allergy in the United States. Then, for the remainder of this talk, I will attempt to summarize and share exciting emerging treatment options for food allergy, including oral immunotherapy, epicutaneous, otherwise known as patch immunotherapy, sublingual immunotherapy, and the recently published data on the use of a biologic in food allergy. This slide is just to orient the audience that while there are many types of adverse food reactions commonly referred to as food allergy, I will be focusing on IgE-mediated, potentially anaphylactic food allergies as opposed to other food allergies or food-triggered conditions such as eosinophilic gastrointestinal disorders, food protein-induced enterocolitis, enteropathies, proctocolitis, lactose intolerance, celiac disease, and other digestive disorders. IgE-mediated, potentially anaphylactic food allergy affects 32 million Americans and approximately 8% of children, which is approximately 1 in 13 children, or 2 kids in every classroom. The most commonly implicated food allergens early in life are milk and egg, which are often in 80% outgrown by grade school. These foods are quickly replaced with peanut, tree nut, and seafood as the top 3 contenders with increasing age. We also see a modest amount of wheat and soy legume allergy, with sesame rounding out the top 9 most common food allergens seen in the United States. These results are from a parent report survey of over 38,000 households in the United States between 2015 and 16 and shows the most common food allergens reported in children. The white bars represent parent report of food allergy, while the gray bars in the middle represent percentages of patients with convincing histories of food allergy as assessed by the investigators according to stringent criteria. And then the black bars show the percentages of patients reporting physician-confirmed diagnoses of food allergy. As you can see, peanut ranks number 1 in the physician-confirmed allergy, affecting 1.8% of the pediatric population, 1.8% of the pediatric population, followed by milk, shellfish, and the collective group of tree nuts. Multiple studies have shown that food allergy prevalence has been increasing worldwide for the last 20 years. There are many hypotheses for this, including the hygiene hypothesis, which recognizes an increased prevalence of food allergy in industrialized parts of the world, with lower rates of food allergy in more rural parts of the world, and even within respective parts of the same nation. Supporting data shows that less sanitation and higher rates of farm animal exposure with microbial diversity and endotoxin exposure early in life is associated with less food allergy and atopy in general. It's theorized that these stimuli may influence polarization of the immune system from a default type 2 helper T lymphocyte mediated atopic predisposition to an innate and type 1 T helper cell mediated inflammatory state. This pictogram incorporates several hypotheses, including the dual allergen exposure hypothesis, where we see increased peanut allergy in infants raised in households with high environmental peanut allergen exposure, and less allergy when the allergen is consumed by the infant early in life. In other words, we think that one is likely to develop sensitization and the potential for allergy to an allergen through inflamed skin, and is more likely to develop tolerance to the food if exposure is balanced in the GI tract. A restricted microbiome also appears to play a significant role, as previously mentioned, as well as possible vitamin D status. However, currently studies in that area are conflicting. As of 2024, the standard of care for food allergy includes establishing the diagnosis by discerning that if the history is consistent with food allergy, and then confirming the history with allergy testing and/or a formal food challenge when the history is not clear or compatible with the testing. Once the diagnosis is established, patients and caregivers are advised on avoidance measures and supplied with the tools and education necessary to identify and treat reactions in the event of future accidental ingestions. Patients and parents are then followed to reinforce understanding of these important concepts and to monitor for comorbidities, as well as to assess for the potential for some patients to outgrow their allergy. Keys to establishing the diagnosis include the presence of immediate IgE-mediated symptoms such as urticaria, angioedema, diffusely flushed skin, persistent scratching or rubbing of the eyes, face, skin, runny nose, sneezing, ocular injection, vomiting, cough, labored breathing, and/or sudden behavioral changes, such as sudden crying or quietness, which could be due to pain or cramping. These symptoms are observed within minutes to 1 to 2 hours of ingestion and should be reproducible every time the child is exposed to that food and only when exposed to that food. While additional tests like basophil activation testing and epitope mapping are currently under investigation, as of 2024, standard testing for food allergy remains serum IgE testing and skin prick testing, both of which have fairly good sensitivity, but frustrating low specificity for diagnosis. This is why oral food challenge remains the gold standard for diagnosis. Unfortunately, food challenges are both time and labor intensive, not to mention stressful for the patient, parent, and provider, as they can lead to anaphylaxis. In addition, outpatient food challenges are not reimbursed well. So between this unfortunate reality and the risks for anaphylaxis, many non-hospital-based allergists, I was one of them, do not offer food challenges regularly enough to meet the true needs of the food allergy community. Whenever discussing the standard of care for food allergy, I would be amiss not to mention the importance of a food allergy action plan. This one is from the Food Allergy Research and Education Consortium, also known as FAIR, and is available at www.foodallergy.org. This plan lists symptoms with pictures of mild reactions and severe reactions with step-by-step instructions for administration of epinephrine and antihistamines, as well as bronchodilators if there's a history of asthma. And on the back side, there is an updated list of currently available self-injectable epinephrine devices with instructions on how to use each one. Putting it all together, this is a basic algorithm for food allergy diagnosis and management. I want to take this opportunity to reiterate that food allergy testing by serum IgE or skin prick testing has a 20 to 50% false positive rate, which is actually even higher in kids with eczema. This rate in children, this is why we do not recommend any food panel testing in children under any circumstances ever, as it can be very misleading in the setting of an absent or inconsistent allergy history. These are the different types of self-injectable epinephrine devices that are currently on the market, with the least expensive form of epinephrine in the middle in the glass ampule. Epinephrine is the only medicine that has been proven to be reliably effective in treating anaphylaxis. For our new interns starting with us, this self-injectable medicine should be injected intramuscularly using the 1 milligram per milliliter concentration, otherwise known as 1 to 1,000. The dose is 0.01 milligrams per kilogram with a max dose generally of 0.3 milligram. It works best when it's used early in an anaphylactic reaction, and we always advise patients to carry 2 doses with them at all times in case the first device malfunctions or is mishandled or is simply just not effective in controlling anaphylaxis. So after that brief summary of the standard of care in the diagnosis and management of food allergy, I want to spend some time addressing how the primary prevention of food allergy has evolved over the last 25 years since I became a pediatrician, and especially how it's evolved even more in the last 5 years. It's hard to believe, but back when I was a pediatric resident, we did not have smartphones. We read paper journals, and we went to the library when we wanted to research things. Around this time, I distinctly remember receiving a widely disseminated publication from the American Academy of Pediatrics Committee on Nutrition, officially recommending avoidance of peanut and other allergenic foods for the first 3 years of life, especially for atopic children with siblings or parents who also had food allergy. This all was recommended with the intent to prevent food allergy. I'm ashamed to admit I dutifully spouted these recommendations to the parents of my patients and junior residents and basically anyone who would listen. And then over the next 15 years, much to our collective dismay, pediatricians and allergists saw the prevalence of food allergies do nothing but skyrocket. Thankfully, around 2008, an astute pediatrician in England made an observation that atopic children from Israel developed more peanut allergy when born and raised in England than children with similar phenotypes and family histories who were born and raised in Israel. While differences in genetics, lifestyles, and perceived risk factors for atopy between these two cohorts were considered minimal, a major difference was that kids raised in Israel were introduced to peanut early in life in the form of peanut puffs, otherwise known as bomba, as a weaning food instead of the traditional English teething biscuit. This observation led to a truly remarkable landmark study by the same authors known as the LEAP trial, or Learning Early About Peanut Introduction, which was published in 2015. The findings from this trial have since led to a complete 180-degree turn around in how we think about food allergy prevention. The LEAP trial looked at 640 high-risk atopic infants less than 1 year of age with severe eczema and/or egg allergy who were known to be at risk for peanut allergy. They were tested for peanut and then randomized to a peanut consumption group of 2 teaspoons of peanut butter 3 times a week for the first 5 years of life versus the standard avoidance recommendations for the first 5 years of life. After 5 years, among 530 infants who initially had negative allergy testing, the prevalence of peanut allergy at 5 years of age was 13.7% in the avoidance group and only 1.9% in the consumption group. The center graph shows the impact of this intervention on 98 participants who initially had low positive allergy test results, but then passed a peanut challenge. The prevalence of peanut allergy in this subset at 5 years was 35% in the avoidance group and 10.6% in the consumption group. Overall, this study showed that consuming peanut early and regularly, again, 2 teaspoons 3 times a week, reduced the development of peanut allergy by 86% at 5 years of age in high-risk children. This study led to the National Institute of Allergy and Infectious Disease guidelines, which were published in 2017, which recommended early introduction of peanut around 6 months of age for children with mild to moderate eczema. These guidelines also recommended allergy testing and/or allergy referral for the highest risk infants with severe eczema or who already had developed egg allergy before they were to introduce peanut. Testing, if negative, was then followed by introduction, and if positive, was followed by allergy consult and food challenge. This is another version of the NIAID approach, which was published in Pediatrics in Review in 2019. I am showing these two slides for one reason and one reason only, and that is to make the point that if you put this flow chart on a bulletin board or in a workstation, pull it off and throw it away and or delete it from your memory, as these guidelines have thankfully recently been updated. There are several reasons for this, one being a problem surrounding how to recognize truly severe eczema and who needs a referral or testing or specialist intervention prior to introduction. Not only were there major flaws in determining who and when to test, the waiting for the testing or specialist referral completely undermined the goal of early introduction in the highest risk patients. All the while that we were slowing things down here in the United States, other countries like Australia and many in Europe took a much simpler approach and basically told everyone, regardless of other food allergies, family history, and or eczema status, to just introduce peanut in age-appropriate forms at 4 to 6 months of age when showing a readiness to eat stage 1 solids. These countries, with many fewer resources and specialists, showed us in the United States how to be successful in getting peanut into their population's diet earlier and safely. So in January 2021, allergists in the United States and Canada got together and published this consensus document in the allergy literature, not acknowledging that while eczema is a risk factor for IgE-mediated food allergies, 25% of children who develop food allergies do not have these risk factors, and many can benefit from early introduction as well. Interval data since the LEAP trial was robust for both early peanut and egg introduction and the prevalence in the prevention of food allergies. So both are now recommended early. In addition, limited data for other allergens like milk and tree nut have also shown promise. So it is recommended that they are introduced early as well. Most importantly, the authors emphasize that screening prior to introduction is no longer recommended, although it can be performed if preferred by families. Finally, as of November 2023, just a few months ago, 6 months ago or so, these modified recommendations were published in Pediatrics. Again, recommending early introduction of peanut and egg at 4 to 6 months of age without testing, regardless of eczema or other food allergy status, and continuing to feed these foods fairly often, as well as broadening the diet to incorporate other allergens with a goal of achieving diet diversity. Just this month, the LEAP Trio trial was published following up on the original LEAP trial infants who were randomized to peanut consumption versus avoidance in the first 5 years of life. 508 of the original 640 participants were contacted and in many cases challenged again to peanut. What the investigators found was that after 6 to 7 years of inconsistent peanut consumption between 5 and 12 years of age, peanut allergy remains significantly more prevalent at 15.4% of participants in the original avoidance group versus 4.4% in the peanut consumption group. As you can hopefully see the benefits of early introduction of allergenic foods early in life, I wanted to mention factors that can hold this initiative back. The EAT trial, inquiring about tolerance study, was published in 2016 and assessed the impact of early introduction of 6 allergenic foods, including peanut, milk, egg, fish, sesame, and wheat, starting as early as 3 to 4 months of life. This study did not show significant efficacy in the intent to treat analysis, but did show significant per protocol effect for egg and peanut individually. This discrepancy between the intent to treat and per protocol results was thought to largely be due to adherence, which was only 42%. Factors affecting adherence were analyzed, and the investigators found that older maternal age, non-white ethnicity, and lower maternal quality life at enrollment were independently and significantly associated with non-adherence. The authors concluded that caregivers with these factors would benefit from support to achieve early and sustained allergenic food consumption. Additional studies on food allergy prevention are well underway, including aggressive eczema management regimens and probiotics and microbiome studies, as well as the use of early life vaccines like whole cell pertussis and the BCG tuberculosis vaccine, which may polarize the immune system away from an allergenic Th2 pathway. So not only have the recommendations for the prevention of food allergy evolved, but new treatments for the mitigation of food allergy are emerging. I will attempt to give you a feel for these next in what remains of this presentation. Going back to our algorithm for food allergy diagnosis and management, we are now leaving what is considered the standard of care in 2024 and embarking on an exciting journey into what someday may be considered standard treatment options for food allergy management, specifically food allergy immunotherapy. Allergists have been successful in using immunotherapy as a treatment modality for allergic rhinitis and insect venom allergy for over 100 years. Now the same concept is being applied to food allergy. The process involves the systematic introduction of tiny amounts of food allergen, followed by gradual increases in doses with the intent to prevent or attenuate systemic reactions with accidental ingestion of small amounts of allergen. Immunotherapy induces a state of desensitization, which is not a cure, but a transient upward shift in which the threshold of reactivity to an allergen is elevated as a result of ongoing controlled exposure to that same allergen. This is an example of one of many oral immunotherapy protocols. Small and increasing amounts of allergen are provided under observation at the allergist's office every 2 to 3 weeks. They're observed for an hour or an hour and a half. If the dose is tolerated, then that dose is continued once daily at home for 2 to 3 weeks before returning to the office for another updose under observation, which is represented by the stairs in this diagram. The updosing phase takes about 6 months if things are going well. Or in this protocol, 11 additional allergy clinic visits. After the updose phase comes the maintenance dose phase, which in this case is 300 milligrams, or the equivalent of about 1.5 peanuts, small peanuts. This amount is taken daily and indefinitely to maintain the state of desensitization. And yes, peanuts come in different sizes. Virginia peanuts are huge, and then the runner peanuts, which are like in peanut M&Ms, are smaller. So depending on what literature you're reading, you may see some different food protein equivalents, which has been a big topic of debate lately for our clinic. So to illustrate the impact of such a regimen, I will discuss the AR101 study, which was published in 2018. The study enrolled close to 500 4 to 17-year-olds who demonstrated significant allergic reactions to 100 milligrams or less of peanut protein on double-blind placebo-controlled food challenge. In other words, the patients enrolled in anaphylaxis to about a third of a peanut. Oops, I apologize, I got to go back here. After 1 year of therapy with a final maintenance dose of 300 milligrams, 67% of the participants in the OIT treatment group tolerated at least 600 milligrams or 2 peanuts on food challenge with minimal symptoms, as compared to only 4% of those in the placebo group. 50% of participants tolerated 1,000 milligrams or approximately 5 peanuts at the exit challenge. In addition to raising the threshold of ingested protein that causes a reaction, the reactions on repeat challenge were less severe in participants who were in the OIT treatment group. This AR101 study and many other studies with different food allergens since prove that for a person who has a very low threshold for anaphylaxis to a small amount of food protein, controlled provision of small amounts of that food allergen daily can raise the threshold to at least the amount given daily, and in many cases 2 to 5 times that amount, and even higher in a small number of recipients. It's not a cure for food allergy, but can mitigate reactions or protect one from severe reactions after an accidental ingestion of a small amount of the food allergen. This is sometimes referred to as making one, quote, bite-proof, and is meant to be used in conjunction with a peanut-avoidant diet. Side effects in the AR101 study and with OIT in general are not uncommon. Abdominal pain, nausea, throat irritation, and itching are the most common side effects. The risk of eosinophilic esophagitis, which is not uncommon in patients with atopy in general, has been found to develop in 3 to 5% of patients undergoing OIT and may potentially be higher in patients who discontinue therapy secondary to GI symptoms and never get scoped. Anaphylaxis tends to occur at an increased rate versus that with food allergen avoidance. In this study, the incidence of anaphylaxis was 8.7%, which is over 5 times more common than the treatment group, or which was 5 times more common in the treatment group than the placebo arm. Anaphylaxis as a side effect has been reported in other studies to be even higher, around 12 to even 20%, especially in older age groups. Since the medication is taken daily, the risk is present daily. While it is more common in the updosing phase, it can occur after years of uneventful therapy. Several meta-analyses, including the PACE study, have confirmed that the risk for anaphylaxis and need for epinephrine is actually increased 2 to 3-fold in comparison to the standard care of practicing strict food avoidance. Through providing this therapy, we as an allergy community have learned a lot about factors that increase the risk for anaphylaxis. One of the toughest factors for patients to deal with is the exercise factor, or anything that increases the body temperature or metabolic rate. With the FDA-approved product, patients are advised to avoid exercise or showering for 3 hours after a dose and for 1 hour prior to a dose. The risk for anaphylaxis is always also increased when the dose is taken on an empty stomach or with NSAIDs or alcohol. Lastly, the risk for anaphylaxis with daily dosing is increased when the patient is ill or recovering from surgery, when they are sleep deprived, and during their menses. The AR101 study has led to the approval of pharmaceutical grade and distributed Arikis hypogea powder, also known as Palforzia. This was approved a couple weeks prior to the start of the pandemic. We started it offering here at UPMC Children's Hospital of Pittsburgh about 2 years later in February of 2022. Unfortunately, it's only approved right now for ages 4 to 17 years. It did not show much benefit in older age groups, and conversely, it may be even more beneficial in younger age groups, which I will discuss later. Contraindications for this therapy include poorly controlled asthma, anaphylaxis on the first day of dosing, suggesting a high risk for subsequent reactions, and pre-existing underlying eosinophilic gastrointestinal disease. Also, it has not been studied in pregnancy. As you can gather, OIT programs have a lot of rules for the parents and caregivers to follow, and teenagers when they get older. Ideally, children should be observed for 1 to 2 hours after a dose, and they should always take it with a meal or snack. Doses should be held when the patient is sick or after surgery or when sleeping over at someone's house or at camp. Depending on the number of days and doses missed, we may require the patient to follow up for redosing in the allergy office. As you can imagine, it is a lot for patients and families to consider, and quite a bit of responsibility is put on the caregiver's shoulder. In response to these issues, we've created an extensive counseling program here, which provides an opportunity for shared decision-making for these families. In summary, the benefits of OIT include mitigation of food allergy with reduced risk for severe reactions on accidental ingestion and a lower likelihood to experience a severe reaction if there is an accidental ingestion of a small amount of allergen. Unfortunately, for most, OIT is not a cure for food allergy, and one must still read labels, practice avoidance, and have 2 doses of epinephrine at all times. Many allergy practices across the United States and across the world have started to offer OIT for other allergens besides peanut using store-bought food. This includes many private practices and academic medical centers, which offer it not according to research protocols, but more along the lines of a quality initiative. As of 2024, we still have a lot of questions regarding OIT. What we know is that it can raise the threshold amount of allergen that leads to a reaction, and it can reduce severity when a small amount is ingested. We do not know how to predict which patients will not respond to the therapy and who will have the most side effects. We also can't predict which patients may naturally outgrow their allergy without intervention. For some patients, OIT is life-changing and liberating, but for others, with all the rules, side effects, and dosing fatigue, we do not always see quality of life improve. Then, when therapy is stopped, for most patients, especially older patients, the level of protection wanes as opposed to the concept of sustained unresponsiveness. Before I jumped into the concept of sustained unresponsiveness, I thought this would be a good time for another little pause in the action. Okay, we think sustained unresponsiveness is an ideal goal of any food allergy therapy. It is defined as a period of non-reactivity while not receiving treatment, which in essence would allow for cessation of therapy without a reduction in the previously achieved elevated threshold or eliciting dose. Sustained unresponsiveness at a minimum can allow for gaps in doses without risk for anaphylaxis when therapy is resumed. and ideally allow for ad libitum intake without prescriptive frequency or amount. Unfortunately, formal criteria for sustained unresponsiveness has not yet been defined, so studies looking at this use various durations of time off therapy that are not directly comparable. To further illustrate the concept of sustained unresponsiveness, I'm going to share data from a fairly recent systematic review of OIT, which was primarily milk, egg, and peanut with a smattering of other foods. This review involved participants aged 4 to 17 years, just like the FDA-approved product, for peanut. The review ultimately showed an overall desensitization rate of 75% and sustained unresponsiveness rate of only 30 to 35%. These findings and those found in many other trials on OIT have led us to two conclusions. One, OIT does not work for everyone. And two, over 2/3 of those who undertake OIT is considered to be a lifelong therapy in order to maintain the benefits of an elevated threshold of reactivity. To further illustrate the concept of sustained unresponsiveness, I will discuss the POISE trial, which enrolled 120 patients aged 8 to 14 years who reacted to less than 500 milligrams of peanut protein on food challenge, which is the equivalent of 2 to 3 peanuts. Patients were randomized to high-dose peanut OIT at 4 grams a day, which is about 18 peanuts or a tablespoon of peanut butter, or placebo for 2 years. After 2 years on repeat challenge, 84% in the treatment group passed a 4-gram peanut challenge versus 4% at placebo. At this point, patients represented in the blue bars were switched to low-dose daily peanut oral immunotherapy at 300 milligrams a day, which is the current FDA-approved dose, while participants in the red bars were placed on placebo. So essentially, they stopped therapy entirely. Then they underwent serial double-blind placebo-controlled food challenges every 3 months for a year. After 3 months, only 35% of the patients in red who stopped OIT passed the same food challenge they passed before. And after 12 months, only 13% or 8 of 60 passed their food challenge. Of the 35 patients who were randomized to the lower 300 milligram daily dose of peanut in the blue bars, after 3 months, only 54% passed that 4-gram blinded food challenge. And after 1 year, only 37% passed. I want to contrast the information from the POISE trial and the prior meta-analysis with the data from the IMPACT trial, which assessed oral immunotherapy outcomes in much younger children. Children aged 1 to 4 years were treated with an OIT regimen reaching 2 grams of peanut daily, which is about 9 peanuts or 3/4 of a teaspoon of peanut butter versus placebo. After a little over 2 years, 71% in the treatment group versus 2% in the placebo group were able to tolerate a 5-gram peanut challenge, way higher than the other challenges we were talking about. This is about 24 peanuts or 1.5 tablespoons of peanut butter. Therapy was then held for 6 months. Repeat food challenges were performed and only 21% passed the challenge, so actually lower than the POISE trial. But what was striking to us and many allergists, however, was that subset analysis of the children who started OIT before 2 years showed 71% sustained unresponsiveness. In addition, the younger children tended to have fewer side effects during their whole OIT course. This is a contour plot using the available data from the IMPACT trial, which shows the predicted probability of remission or development of sustained unresponsiveness in the treatment group using a logistic regression model plotting baseline peanut-specific IgE and age at screening. Values in blue in the lower left show a probability of remission or sustained unresponsiveness higher than 50%, while older age and higher IgE levels at baseline show a probability of sustained unresponsiveness lower than 50% in the red zone. This data, along with the LEAP data, suggests greater immunoplasticity in younger children and infancy, and that there may be a critical age window for safer OIT with an increased likelihood to attain sustained unresponsiveness. So while that contour plot is partly why our allergy division here at Children's has been galvanized into action, I want to take just a moment to further discuss where we are with this data. This chart shows a likelihood of sustained unresponsiveness based on the 2 trials I just mentioned. To recap, 71% of infants who started OIT in the 12 to 24-month age group demonstrated at 6 months sustained unresponsiveness, as compared to 35% in the 2 to 3-year-old age group and 19% in the 3 to 4-year-old age group. In the process of full disclosure, the N on the right is skinny. and showing that the 71% from the impact trial consisted of only 5 of 7 kids in the early OIT group passing the 6-month challenge. Admittedly, we need more data. I want more data. I can't wait to see more data. However, between this data and what we have learned from the LEAP trial, we and many allergy colleagues across the globe expect to see more robust data in the next 5 years, showing higher rates of sustained unresponsiveness and higher levels of safety with less side effects when OIT is initiated in younger age groups. One could argue that the promising data in younger age groups is due to the fact that some children will naturally outgrow their food allergy. This graph is from the Health Nuts population-based longitudinal study from Australia that tracked the natural history of allergic diseases in 5,276 infants, of which 156 originally had peanut allergy. There was a 3.1% prevalence of challenge-confirmed peanut allergy at 12 months of age, with natural resolution in 22% by 4 years of age and 29% of 6 years of age. Now, I have to say that I have not seen this degree of resolution in Western Pennsylvania or even in the United States. And in just Western Pennsylvania, we get a lot of cloudy days. We don't get a lot of sun. I don't know what is up with that, but Australia definitely gets more sun. Maybe that has something to do with it. I don't know. For the sake of completeness, the far right bars show just egg allergy, and that 75% of children will outgrow their egg allergy if we're just patient by age 4 years, and 89% will outgrow it by age 6 years. So the current status of OIT at this time is that Arikis hypogea pharmaceutical-grade peanut powder is the only FDA-approved form of OIT in the United States and is only approved for ages 4 to 17 years at this time. Many institutions are embracing off-label OIT using store-bought food and progressive protocols that generally start at 0.5 to 6 milligrams of peanut, which is like 1/50th of peanut. And they build up to a maintenance dose of allergen that ranges anywhere from 300 to 500 milligrams a day, which is about 1.5 to 3 peanuts. And it's thought to make most patients bite-proof with minimal or mild symptoms after accidental exposure to a small amount. Some protocols are written with much higher goals, such as 4 to 5 grams of food protein close to a serving. But it's not clear how many truly allergic patients can truly achieve this goal safely, and published double-blind placebo-controlled research using high-dose OIT is currently scant. So here's just another little break here to give you a breather before we jump into some other therapies. So with the remainder of my time, I hope to briefly touch on other emerging forms of food allergen therapy, but we'll move quickly to allow for audience questions at the end. Epicutaneous immunotherapy is also in phase 3 research trials with promising results. There is one set dose and every day a sticky patch containing 250 micrograms of peanut. So a microgram is less than 1,000th of a milligram. It's a very small amount. It's placed on the back, typically on the back so the kids can't scratch it off, in a new location every day. The goal was to wear this for about 20 hours a day, and the most common side effect is localized itching and definite eczema inflammation under the patch site. It's really cool though, because as the year goes on, the skin doesn't react anymore, and we put steroids on it if they're reacting after we take the patch off, but it's so neat to see the skin start to learn how to accept the allergen when it's provided in small amounts daily. The PEPITES trial in 4 to 11-year-olds showed that after 3 years of wearing the patch, the thresholds for reactions were raised significantly from less than 100 milligrams, or a third of a peanut, just like the AR101 trial, to over 300 milligrams of peanut in 2/3 of the patients. The orange bubbles at month 36 showed that the eliciting dose thresholds were raised to over 1,000 milligrams, or over 4 to 5 peanuts in 50% of patients. I put the tortoise and the hare picture here only to suggest that it takes much longer for this form of therapy to work than OIT. Whether or not the tortoise wins in the end, however, is totally unknown. We do not have any sustained unresponsiveness data yet. The EPITOPE trial is another peanut patch study that I have had the privilege to be involved in that was just published in the New England Journal of Medicine last year, looking at the use of the patch in younger kids with more immunoplasticity, age 1 to 3 years, as opposed to 4 to 11-year-olds. This study showed that after 1 year of therapy, 2/3 of peanut patch receiving subjects met responder criteria, as opposed to 1/3 of patients receiving the placebo patch. This study is ongoing to assess response rates after 3 years of therapy, and I had a chance to peek at the data for these 1 to 3-year-olds at the 2-year point, and it's definitely better than what you see here, and better than what we see, not surprisingly, in the Pitt trial in the older kids. I just can't show it because it hasn't been published yet. So in addition to the EPITOPE trial, larger proportions of patients in the patch therapy group had milder symptoms on food challenge after only 12 months of therapy, with even a larger proportion of patients with milder symptoms in the soon-to-be published 2-year data. I want to point out that epicutaneous immunotherapy uses significantly lower dosing, micrograms versus milligrams. EPIT avoids oral allergen ingestion, so it has fewer side effects, a high degree of adherence in the studies, and fewer dropouts. Side effects include those local skin reactions that I mentioned, and rarely anaphylaxis. It can happen. There's usually probably multiple factors involved with that, including exercise and getting overheated. So we're coming around to the final bend of emerging allergy strategy as part of this talk. The next contender to discuss is sublingual immunotherapy, which I really think is it's worth discussing and considering. Sublingual immunotherapy was initially studied in older children 4 to 17 years of age and showed a 70% response rate versus 15% in placebo, with mostly oropharyngeal side effects and few mild anaphylactic reactions. A similar study was just published this year, examining the effect of sublingual immunotherapy now in 1 to 4-year-olds, again with greater immunoplasticity. There were 50 patients randomized 1-to-1 to receive sublingual therapy, starting at 2.5 micrograms of peanut, so even less than what's in that patch. It's just a microscopic amount. I don't even know what to tell you to compare that to. And then building up to a maintenance dose of 4 milligrams of peanut protein, which is like 1/50th of a peanut, versus placebo. After 3 years of therapy, 79% of the 1 to 4-year-olds in the per protocol population tolerated over 4 grams of peanut protein with minimal symptoms, as opposed to 0 in the placebo group. Then 3 months after cessation of therapy, not quite the 6 months data that I showed you in the IMPACT trial, 63% of per protocol participants passed the same 4-gram food challenge, which is about 18 peanuts or a tablespoon of peanut butter. Similar to the IMPACT trial I discussed earlier, the earlier initiation of therapy led to better outcomes, higher proportions of 1 to 2-year-olds, specifically 75% in the intent to treat, and 100% of the per protocol 1 to 2-year-old patients tolerated the 4-gram challenge. Additionally, a larger proportion of the 1 to 2-year-olds, specifically 58% in the intent to treat and 78% in the per protocol group, showed sustained unresponsiveness 3 months after cessation of therapy. So here's yet another study showing that the earlier you intervene, the better. My intent with this slide is to give a brief and general glimpse at what is currently available as biomarkers to use in these studies. So it not just applies to SLIT, which this picture is from, but also with other immunotherapies like OIT and EPIT. In general, skin prick test wheal size and peanut-specific IgE levels diminish, while peanut-specific IgG4 levels uptrend. This is just a point that do not draw any food allergy IgG levels for any sort of medical problem that exists, because it's going to come back positive if people are eating that food. There is quite a bit of, we think IgG4 is protective, and it's one of the things the body does when it's responding well to OIT. So hopefully we will put that myth to bed that IgG4 levels are helpful for IgE-mediated food allergies. It might be helpful in celiac disease, especially in IgA deficient patients to assess that, but it's probably not even IgG4 that we're assessing when we check that. It's probably the whole gamut, IgG1 through 4. But I'm off on a tangent, so I'm going to get back on here. There's quite a bit of overlap, as you can see, between these treatments, those on treatment and those receiving placebo. And this reflects the previously mentioned limitations in testing, not only for food allergy diagnosis that I mentioned earlier, but it also reflects the challenges that we see in assessing efficacy of treatment modalities. And basically, it reflects our current ongoing reliance on these time-consuming and resource-intensive double-blind placebo-controlled food challenges to measure treatment response. So with that being said, the last treatment modality for food allergy that I will touch on today Was recently published in late February of this year involving the use of omalizumab, a monoclonal anti-IgE antibody, which was originally approved for asthma almost 20 years ago. And they're now trying it in patients with multiple food allergies. These results are from the first stage of 3 stages of a trial using omalizumab initially as monotherapy for food allergy, and then the second phases are going to use it with OIT. Approximately 177% or 177 participants aged 1 to 17 years underwent double-blind placebo-controlled food challenge to 2 or more of their food allergens, and were then randomized 2 to 1 to treatment with omalizumab versus placebo. After 4 months of therapy, participants were challenged again, and the increase in doses provoking anaphylaxis were measured. Approximately 67% of participants receiving omalizumab were able to tolerate 600 milligrams of peanut, approximately 2 peanuts, or more, and 1,000 milligrams or more of other food allergens such as milk, egg, wheat, and walnut. The exception was cashew. The cashew allergic patients didn't seem to respond as well to this therapy. Disappointingly, only 41% were able to tolerate 1,000 milligrams on challenge after 4 months of omalizumab therapy. Retention for the study was high at 97%. Side effects were minimal and included injection site reactions. 69% of participants were able to consume 1,044 milligrams of 2 food allergens, with just under half, or 47%, consuming over 1,000 milligrams of 3 unrelated food allergens, making this therapy not only effective, but also allergen agnostic, as opposed to the other 3 treatment modalities that I discussed today. Notably, 14% of participants were not responders and could not even consume more than 30 milligrams of peanut protein without dose-limiting symptoms, which is essentially considered a treatment failure. There are many other really cool potential biologic interventions that are currently undergoing investigation, including other anti-IgE therapies like ligelizumab, anti-IL-4 and 13 monoclonal antibodies, anti-thymic stromal lymphopoietin, and other anti-enlarvement therapies, as well as Bruton tyrosine kinase inhibitors that are currently deployed as cancer therapies. These also have been shown to prevent food anaphylaxis. So there's a lot going on in the field of food allergy, and I've only touched on the surface of it. If nothing else, I hope I was able to give you a basic understanding of the variability of food allergy reaction thresholds and the approach to assessing food allergy treatment efficacy with food challenges. My hope is that you now have a foundation to build on as new treatment modalities continue to appear on a very bright horizon. I briefly mentioned earlier in my talk that health disparities can impede early introduction of food allergens and food allergy prevention. Disparities in healthcare impact so many facets of food allergy. The newer treatment strategies have the potential to further widen these gaps. So we need to be cognizant of these issues and thinking of ways to promote equity as we navigate this evolution. I can tell you that as a primary investigator of many of our studies, it is really hard to get anyone to sign up for multiple double-blind placebo-controlled food challenges. The food allergy research community is aware of this, and that we have underrepresentation of various ethnic and cultural groups and those with lower socioeconomic status, and we're working towards solutions in these areas. With the last few minutes of my time today, I wanted to touch on how our division of allergy immunology here at UPMC Children's is attempting to navigate these rapidly evolving treatment strategies in food allergy, many of which are not even FDA approved. As I mentioned, we offer the FDA-approved Arikis hypogea powder for peanut allergy, children aged 4 to 17 years. We've also started to prescribe anti-IgE therapy, which is approved for ages 1 to 55 years. However, insurance approvals for this are currently few and far between. We are also active in industry trials involving some of the therapies that I mentioned in my talk today. But what we as an allergy immunology division are most excited about is the progressive launching of early immunotherapy in children less than 3 years of age with food allergy who have greater immunoplasticity and who may have the best chances for sustained non-responsiveness with fewer side effects. For our early OIT program, we decided to adopt a protocol published by Leon Solar's group in Canada, which was considered a quality improvement project and not a trial. We like this protocol using Baba Puffs because it did not involve the use of scales or little measuring spoons. In addition, caregivers can easily find Baba Puffs over the counter and don't have to do large searches online for different nut powders. The group published the real-world safety data on 270 infants aged 9 to 71 months who either had a history of peanut reaction with confirmatory testing or no history of reaction, but markedly elevated IgE greater than 5 Ku per liter. 243 children underwent updosing to a maintenance dose of 300 to 320 milligrams of peanut protein, similar to the FDA-approved product. 10% dropped out. 4% of patients received epinephrine during their build-up dosing in the office, one of which was very serious. The incidence of EOE in their study was much lower than what is reported in early children and was only 0.37%. 98% of participants were able to tolerate 1,000 milligrams of peanut protein, or 4 to 5 peanuts, or a teaspoon of peanut butter, that's the equivalent, on food challenge after 1 to 3 years of therapy, while over 3/4 of patients could tolerate 4 grams, which is about 18 peanuts or 1 tablespoon of peanut butter. This is significantly better than the AR-101 outcomes and the POISE trial data, which are used much higher daily doses of OIT that I showed earlier. I'm hoping this group will publish their sustained unresponsiveness data soon. However, since this is a real-world effectiveness publication, we will not have the benefit of pre and post eliciting dose threshold data that we see with the double-blind placebo-controlled food challenges. This group had published additional safety data separately, showing less adverse events in children who started therapy as infants versus those who started a few years later. While there were a few reactions requiring treatment with epi in the buildup phase, no serious reactions were reported during the maintenance phase at home in the infants. So over the last 15 months, with the support of every provider in our division and our nurses and our administrative leadership, we have enrolled close to 50 peanut and cashew nut allergic patients, less than 3 years of age, with enthusiastic caregivers in our early OIT program, using many of the same concepts that we use for the FDA-approved peanut OIT program that we started in 2022. We are currently building the program, and we are thankful for the support of our nurses and our administrative leadership enabling us to do this. We as a division are very grateful to our UPMC Children's Hospital of Pittsburgh leadership, as we've been given more space that we desperately need to expand our program. We recently moved into the unused dental space on the first floor of Children's North. This gives us more space to schedule the OIT updoses and monitor the patients for an hour, hour and a half after their updoses. We moved in about 3 months ago, and we're still in the process of settling in and optimizing our workflows and patient experience. The little sinks on the right, I took a picture of them because they're a hit. Little ones can wash their hands after they get done eating their allergen, and we just try to keep them from playing in it. So this is one of my little patients who I just updosed yesterday to 1 stick of Bomba, and that is his mom in the picture, not one of our nurses, just in case you were wondering. We hope to expand our program over the next few years as we look to adopt more effective and safe protocols to other foods. Hopefully in a couple years, we will be able to update you on not just food allergy treatment progress across the globe, but also our own progress here at home. And that's about it. I went a little bit over because I wanted to leave time for questions. I just want to thank all the providers in our division and my division chief, Dr. Chong, for trusting me to give this talk today. And all of our fellows that have been working on various initiatives and helping us do our food challenges, as well as our research food challenges, and all of our nurses, Sarah and Linda. I want to thank you so much for working with us and navigating this journey with us. I want to give a shout out to Nicole Cascone, who is our food allergy nurse coordinator that schedules all of our challenges and has taken the lead in coordinating all of our Palforzia patients. They just love her. I want to thank all the nurses at Children's North who have put up with me up there doing all these different food allergy things, and Kara Coffey, who has been a huge force as well at the North. And I want to shout out, thank you for giving me the tips on the cartoon, Kara. That was really helpful. I want to thank Craig, who is leading all of our research studies, and also shout out to Liz Hardigan, Jamie Adams, Lynette Milkovich, and Susan Ritchie, who also have been working with us on our food studies. And then Barbara DeFusco, Joanne, and most importantly, Kathy Piccolino, God bless her. She is our scheduler. She works so hard, and we have so many patients that need scheduled for so many different things. And then adding this OIT scheduling on top of it has been a huge challenge, and she has hung in there with us, and we're so grateful for her. So that's about it. And hopefully we have some time for questions.